Hi, my name is Jennifer Woyach, and I'm really happy to be talking with you all today about chronic lymphocytic leukemia, or CLL. So during this short talk, we'll start by discussing some of the biology and natural history of CLL and its tissue counterpart, small lymphocytic lymphoma. We'll talk a little bit about the criteria for the initiation or starting of therapy. We'll talk about specific therapies for CLL and SLL, and then spend a few minutes discussing what may be coming next, things that are currently in clinical trials and looking very promising. So CLL, for those of you who are a little less familiar with the disease, is often considered a disease of what we call disordered apoptosis. So apoptosis is a programmed mechanism by which cells die. And all cells are supposed to do this at certain times in their lifespan. And with all cancer cells, and including CLL, the cells don't die. They just continue to accumulate. And in CLL, the cells will accumulate then in the lymph nodes, in the bone marrow, and in the spleen, as well as kind of free flowing in the peripheral blood between those different niches. And when the CLL cells accumulate in those areas, they can cause symptoms. So when the CLL cells accumulate in the lymph nodes and continue to proliferate in the lymph nodes can become enlarged. Usually with CLL, the lymph nodes themselves are not painful, but it can be uncomfortable when they get enlarged to the point where people feel them when they turn their neck or feel them when they move their arms or their legs. When CLL cells accumulate in the spleen, this can cause the spleen, which is located on the left side of the abdomen, to become enlarged, and this can actually press on the stomach and cause something that we call early satiety, where people get full really quickly when they eat a meal. So instead of being able to eat, a hamburger in one sitting, people can eat just 2 bites and then become really full. And this can cause weight loss. And also large spleens tend to release a lot of inflammatory proteins that just make people feel kind of crummy. As well, when CLL cells fill up the bone marrow, they can actually prevent normal blood cells from being formed. So people will develop anemia, which is low red blood cell count, or thrombocytopenia, which is low platelet count, just because the precursors aren't able to be made in the bone marrow. CLL cells also will disrupt normal immune cells. So even if there are normal numbers of other immune cells like T cells, neutrophils, the CLL cells release a lot of immunosuppressive proteins that will cause those other cells not to function the way they're supposed to. And then some of you may have heard of or even been diagnosed with SLL, or small lymphocytic lymphoma. This is actually the exact same disease as CLL. However, it is predominantly in the lymph nodes rather than in the blood. So we use a count of 5,000 CLL cells per microliter of blood, where we kind of make that distinction between CLL and SLL. Most people who are diagnosed with SLL will become CLL at some point in the course of their disease, so this can happen at varying times. So CLL is a really heterogeneous disease. So some people, when they're diagnosed, will need treatment right away. So people will need multiple treatments within their lifespan. Other people may go their entire natural lives without needing any treatment for CLL. One thing that's been very helpful over the past decade to 2 decades now is the introduction of a number of prognostic factors, which can help somebody who's newly diagnosed know which one of those groups they're likely to be in, someone who's going to have more aggressive disease or someone who's going to have more slow-growing disease. There's some common factors that we use. I'm going to go through a few of the more complicated ones in more detail, but the first one is the stage. And so this is kind of just the extent of the disease. In CLL, we consider stage 0 to be lymphocytosis alone, so just an elevated white blood cell count without anything else. And then it kind of goes up from there with other accumulation of symptoms. Lymphocyte doubling time is exactly what it sounds like, the amount of time it takes for the lymphocyte count to double. And we know that people whose lymphocyte doubling time is less than 1 year have more aggressive disease than people whose lymphocyte count does not double within the course of the year. And that's pretty explanatory. Beta-2 microglobulin can be secreted by CLL. Higher levels of beta-2 microglobulin also indicate a little more aggressive disease. So the other prognostic factors, IGHV mutation This involves the receptors on the surface of the CLL cells. Mutated receptors are more to normal B cells, and they indicate a CLL cell that was likely derived from a more mature cell and tends to be a little bit more slow growing. IGHV unmutated means a CLL cell that's actually more similar to kind of the newly born B cells in the bone marrow, and those tend to be more aggressive. So what this means clinically, people who have IGHV mutated disease, only about half of those people need treatment within the course of their lifetime. And average time from diagnosis to first treatment is about 10 years. On the other side, you have people with the unmutated IGHV, where basically everybody in that group is going to need treatment at some point. And average time from diagnosis to first treatment is about 3 years. The next prognostic factor, FISH or stimulated karyotype, indicates that CLL cells tend to have abnormalities in their chromosomes or their genes. And this is kind of a hallmark of the disease, and actually a hallmark of most cancers, in that mutations or structural abnormalities in the chromosomes accumulate. We know that there are certain chromosomal abnormalities in CLL, such as a deletion of part of chromosome 13 called a 13q deletion that indicate more slow-growing disease. Others, deletion of part of chromosome 11 or part of chromosome 17 that indicate more aggressive disease. And then finally, we know that people who have a mutation in a gene called TP53, which is a tumor suppressor protein, people whose CLL cells have mutations in that gene tend to have more aggressive disease. Well, one of the big questions that people ask is whether prognosis can change over time. So we tend to do these prognostic studies near the time of diagnosis, or at least prior to the first therapy. And the question is, do we need to keep doing these over and over again? So we know that the IGHV mutational status, so that's the mutated versus unmutated, does not change. Abnormalities in the chromosomes and gene mutations can, and this is a process that's called clonal evolution. So as an example of this, those TP53 abnormalities are seen in about 10% of patients with CLL at baseline, but about 40% of people who have CLL that has been refractory to multiple therapies. This is just a little schematic to help you understand this. So in the beginning, your CLL cells are probably all pretty similar in terms of the mutations or chromosomal abnormalities that they have. During the course of a disease, one of those cells might acquire a new mutation. And then another of the cells might acquire a mutation. So the first mutation is this light red here. Second mutation is this purple here. And maybe that light red mutation gives a survival advantage to those cells. So those kind of grow out more than the original cells in the dark red. And then this purple cell doesn't have much of an advantage, so it kind of just stays. So then when a patient undergoes treatment, a number of things can happen. Sometimes one of the mutations is more sensitive to the treatment, and that clone might go away completely. Sometimes that might happen to multiple clones. So, then when the disease comes back after therapy, it may come back kind of just the same as the original. It may come back kind of where all the cells are the same, but they all have a new mutation in them. They may have acquired mutations in different proportions, or we may see different mutations kind of come out. And this is all important because we know that different mutations will affect how well somebody will respond to certain therapies. And so every time we start a new treatment, we want to check for these TP53 mutations and some of these chromosomal abnormalities to make sure that we're still on the right track with our treatment. So moving along to indications for treatment. So we know that in CLL, there has not historically been an advantage to treating early. And so there are a number of symptoms that we look for as reasons to start therapy. Kind of break these down into different categories. So one is kind of CLL related symptoms. Sometimes we call these constitutional symptoms or whole body symptoms. And they also are sometimes called B symptoms. So these are things like night sweats, weight loss, fevers in the absence of infections, and fatigue. Of these in CLL, fatigue is definitely the most common. Next category would be increases in the burden of disease, so the tumor burden. So these are things like progressive lymph node enlargement, progressive spleen enlargement. When that lymphocyte doubling time gets below 6 months, And this is a little bit of a subjective marker. So if the lymphocyte count goes from 10 to 20 in 6 months, we're probably not going to treat somebody at that point. We'll still continue to watch. If somebody's white count goes from 200 to 400 in less than 6 months, that's probably a time you want to start treatment. And then really uncommonly, you can get enlarged lymph nodes in just unfortunate areas. So like an enlarged lymph node up near the liver where it can obstruct the bile formation, or one that compresses the urine as it moves from the kidney to the bladder. Like those are things that can cause organ dysfunction if they're kind of left untreated. Then bone marrow failure is another reason that we would start treatment, and this would be where the blood count goes below 11 or platelet count goes below 100,000. And then sometimes we need to start treatment because of things like autoimmune complications related to the CLL that doesn't respond to our standard therapies. So as I said, there have been multiple clinical trials that have looked to see whether there's a survival advantage to starting treatment early. So far, none of these studies have shown a survival advantage, but it still remains a really open question, especially as we're getting better and better therapies that are better tolerated, and we're better able to determine who's high risk to need treatment in the future. I wanted to highlight this study. It's called SWOG 1925. It's a nationwide early intervention trial for people within 1 year of the diagnosis of CLL who have high risk disease. And this study is testing a combination of drugs called venetoclax plus obinutuzumab given either at diagnosis or at the time when we would otherwise start therapy to, again, see whether we can improve people's outcomes by treating early. So one of the things, if you have CLL or know people with CLL, you've probably heard a lot about the changes in therapy over the past, 5 years. And targeted therapy has really changed the natural history of CLL. One of the first things that I tell people when they're newly diagnosed is do not look at survival numbers on the internet because they're all outdated. Our therapies are so much better that we really can't estimate how long somebody with CLL is going to live because it's much longer than we were seeing even 5 years ago. So there are a number of therapies that can be used in the frontline setting. We're not going to talk about these in too great of detail, but we're going to go through some of the more common ones that you've likely heard of. So ibrutinib with or without an antibody, acalabrutinib with or without an antibody, venetoclax, and then chemotherapies. So this is a kind of sciencey slide here to show you how some of these targeted therapies work. So two of the drugs that I mentioned, ibrutinib and acalabrutinib, are what are known as Bruton's tyrosine kinase or BTK inhibitors. And these drugs bind to a protein called BTK that is really important in the CLL cell survival and completely shut off the signaling of the CLL cells, which then makes those cells not continue to divide and continue to go sit in the lymph nodes. And the cells kind of just sit there and eventually die. Venetoclax was known as a BCL2 inhibitor. So BCL2 is what is known as an anti-apoptotic protein. So it keeps cells alive. The way it does this is by sequestering proteins that otherwise would cause a cell to die. And so venetoclax takes the place of BCL2 in those pro-apoptotic proteins and actually allows the cell to undergo its programmed cell death. And so it changes the cell from one that is going to be immortal to one that will die right away. So when we think about how we're going to treat somebody, the first question is, are we going to use our standard chemotherapies from the past or the new targeted therapies? There have been a couple of studies, actually a number of studies now, which have showed an advantage to targeted therapies over chemotherapies. One of the most important ones for young people tested ibrutinib, the BTK inhibitor, given with a CD20 antibody called rituximab versus chemotherapy. And this study actually showed a survival advantage to the targeted therapy versus the chemotherapy. So at 3 years after somebody started treatment, the people in the ibrutinib group, 99% of them were still alive, compared to 93% of people in the chemotherapy group. So that tells you people did well in both of those groups, but that really is a pretty big difference between those groups. and shows us that ibrutinib is better than chemotherapy in young people. A similar study was done in older patients with a different chemotherapy regimen and showed the same thing. So ibrutinib, either given alone or with an antibody, was better than standard chemotherapy, in this case, bendamustine plus rituximab. A newer BTK inhibitor is called acalabrutinib, and it's a little bit more selective for BTK than ibrutinib is and a little bit better tolerated. This drug was studied in a trial of older patients, again, in the frontline setting compared to a chemotherapy regimen, and again showed that the BTK inhibitor with or without an antibody improved people's remission time significantly over chemotherapy. The venetoclax, the BCL2 inhibitor, was tested in combination with an antibody called obinutuzumab versus chemotherapy, again, in people with previously untreated CLL. And again, we see that the targeted therapy is better than chemotherapy. So these trials tell us that both BTK inhibitors or venetoclax are more effective than chemotherapy. The two different mechanisms, so BTK inhibitors versus venetoclax, look pretty similar with the follow-up that we have. And so we're really excited to see long-term results to decide which of these regimens is better. And then we think about how we're going to choose between those three very effective targeted drugs. Right now, it looks like the effectiveness is pretty similar, with the possible exception that those patients who have TP53 abnormalities, mutations, may do better with BTK inhibitors. We also know from a recent study that acalabrutinib and ibrutinib are equally effective. The drugs have very different side effect profiles. Ibrutinib and acalabrutinib can sometimes cause cardiac abnormalities, including an abnormal heart rhythm called atrial fibrillation. This is much more common with ibrutinib than acalabrutinib. They can also cause hypertension, again, more common with ibrutinib than acalabrutinib, and they can cause bleeding. Venetoclax can cause neutropenia, which is a lowering of the good white blood cell count, and sometimes can cause some diarrhea or nausea. I didn't mention this before, but the venetoclax regimen is given over the course of a year, whereas ibrutinib and acalabrutinib, they're started and continued as long as they're working. So one of the things that we spend a lot of time talking to patients about when we're deciding on a frontline regimen is some of these intangibles: fixed duration, so a year of treatment versus indefinite treatment. The trade-off with that is venetoclax plus obinutuzumab is much harder to start. It requires a lot of visits up front, whereas a BTK inhibitor is much easier. Between the two BTK inhibitors, one is once a day, the other is twice a day. And then cost can sometimes be an issue, although there are a lot of assistance programs available. And so between insurance and assistance programs, most people will be able to afford these medications. So, if you're in the position of trying to decide on your frontline therapy, this is really one of the, most in-depth discussions that I have with a patient is how to choose among these different regimens, because there's a lot of pros and cons to consider. The good news, though, is there's really not a bad choice here. All of these targeted therapies work really, really well. So what is the future of treatment? So, right now, most times we use these drugs either by themselves or with an antibody. So one oral medicine and one antibody. There's a lot of studies that have been done to look at combining these drugs together. So give ibrutinib with venetoclax, with or without the antibody, give acalabrutinib with venetoclax, with or without the antibody, looking really, really promising and likely to be FDA approved later this year. As well, there are trials looking at giving short courses of chemotherapy and then a novel agent to see if that works better. And so, there certainly are a lot of new therapies and new strategies on the horizon too. I wanted to just mention a couple of the studies that are ongoing right now that are nationwide studies. This one for younger patients called EA9161. This is for people less than age 70 and actually is close to accrual right now. And this study is looking at the triplet, so 3 drugs, ibrutinib, venetoclax, obinutuzumab versus ibrutinib plus obinutuzumab to see which one of those is better than the other. A similar study in older patients is still open for accrual. So this is for people age 70 or older. where people can be treated with either ibrutinib plus obinutuzumab, or again, that triplet, ibrutinib plus obinutuzumab plus venetoclax. And this study is testing whether using response at the end of therapy to determine discontinuation is a good plan. And then there are a lot of exciting new treatments and strategies currently on trials, new ways to target signaling of the CLL cells, new antibodies, and ways that we can use people's own immune system to combat CLL. So some of the oral medicines that are also looking at targeting the B-cell receptor signaling pathway, so besides the BTK inhibitors, we also have PI3 kinase inhibitors, and now we have a number of drugs called reversible BTK inhibitors, ARQ-531, LOXO-305, now known as pirtobrutinib, and others. We have a drug called umbralisib, which is a new PI3 kinase inhibitor, and then a drug called MS-553, which inhibits this protein called PKC, which is also in the same pathway. There's new targets on the surface of CLL cells, so a number of the antibodies I mentioned, the rituximab and obinutuzumab, target a protein called CD20. We're starting to be able to target other proteins like CD19, ROR1, the BAFF receptor, and these things are looking really promising too. And then finally, many of you may have heard of CAR T cells, where you can actually take somebody's own T cells, change them, kind of program the T cells to recognize and kill CLL cells, and then infuse them back in. This is also being done with natural killer cells using a similar sort of mechanism. Again, looking really promising in clinical trials, and we're getting better and better ideas of how to use these appropriately in people with CLL. So, what to take away from this talk? I know I talked about a lot of different things here. I think the most important thing: CLL is a cancer of the blood, bone marrow, lymph nodes, and spleen. Currently, there's no advantage to treating CLL early, though this is still under active investigation. When it's time for therapy, though, there are many excellent non-chemotherapy options. It is hard to choose, but again, no wrong answers in this one. I think one thing we're going to really be talking a lot about over the next few years is, as our therapy for CLL gets better, other issues like preventing infections and screening for secondary cancers are becoming more and more important, because people are living with CLL for much longer periods of time. And a takeaway for you all is ask your doctor about clinical trials. This is how you have access to therapies you otherwise wouldn't, and how we as a group will make the next big leap in CLL therapy. I'd like to thank you very much for your attention, and during the live session, I'm happy to take questions.